Good afternoon, everyone, or potentially good morning to some of our international participants, and a very warm welcome to today's webinar, which is being held in recognition of World Patient Safety Day. I'm Dr. Michael Eden. I'm Clinical Director for Patient Safety and Quality at the College and Consultant Histopathologist at Addenbrooke's Hospital in Cambridge. A few housekeeping things for this webinar. It's being recorded with all participants muted. We will have time for audience questions and comments towards the end of the session. But please do submit your questions, comments via the Q&A function on your control panel, which is on the bottom of your Zoom webinar screen. We'd also love to hear about how your teams are working towards improving patient safety, particularly for children and newborns. And if you'd like to tweet about this event, please tag us at RCPath and use the hashtags World Patient Safety Day and RCPath Patient Safety. The theme for this year's World Patient Safety Day is Safe Care for Every Newborn and Every Child, with the slogan Patient Safety from the Start. Now, the WHO is using this theme to highlight the urgent need to reduce preventable harm in newborn and paediatric care and recognise the unique vulnerabilities of children to safety risks due to their rapid development and evolving health needs. Whilst much of the public narrative around patient safety centres on frontline clinical care, we know as pathologists that every diagnostic decision, lab result, microscope slide can directly influence a child's treatment plan and their long-term outcome. And in paediatrics and neonatology, the margin for error is small, and the consequences of delay or misinterpretation can be very profound. So today, we'll explore how clinical pathological pathways either support or undermine patient safety through case studies that highlight both exemplary practice and critical failings. Our goal here isn't just to share what's gone wrong, but to ask what could have been done differently and how can we build safer systems going forward. As a college, we recognise that patient safety must be embedded in everything we do, not just treated as a separate work stream, but integrated as part of pathology training, practice, and culture, ultimately. And that's why we've established the RCPath Patient Safety Steering Group earlier this year, which, as some of you may know, leads on this agenda and work with all specialties to identify risks, share learning, and drive improvement. And it brings together college representatives, specialty advisors, and also external partners to shape a more coordinated, integrated approach to safety. One of the key tools we already have is our extensive set of RCPath professional guidelines, which are developed across every major pathology discipline. These guidelines set clear expectations for safe practice, promote consistency, and help services align with the highest standards of care. And when implemented fully, these act as a framework for safety, ensuring that every child in every hospital or trust can receive the same quality of diagnostic input regardless of their postcode. We also know that guidelines alone are not enough, and they need to be understood, used in context, and regularly reviewed in light of new and emerging evidence. That's part of what today's webinar is about, understanding where guidelines support safe practice and where gaps or misapplications may exist. So we're very fortunate today to be joined by three of the college's senior leaders, each of whom brings a unique perspective on learning, communication, and quality in pathology. Dr. Croal is the college president and a chemical pathologist who's made patient safety a cornerstone of his leadership agenda. Professor Marta Cohen is vice president for learning and clinical paediatric pathologist. And Dr. Noha Sakka is the vice president for communications and a consultant medical microbiologist and virologist. Together, we'll consider how we as individual pathologists and as a professional community can strengthen the safety and effectiveness of our work, particularly for our youngest and most vulnerable patients. So with that, I'm very pleased to hand over to our first speaker, Professor Marta Cohen. Marta.
Thank you very much. So I offer to present an example of when things go wrong. And this is a case study that we recently shared with my colleague, Dr. Sophie Stenton, and myself. The clinical history was of a 1-year-old female who, with a 10 weeks history of a cystic fluid that was a collection in her little finger. There were raised inflammatory markers and bone changes on the X-ray. So it was initially managed as an osteomyelitis, and it was treated with antibiotics. However, a biopsy of this lesion was arranged. It was a very tiny biopsy, It was a very blunt fibroblastic lesions, and we do a trichome stain just to look if there is a digital fibromatosis, a digital fibroma, and it was negative. There were no inclusions. It was focal staining with beta-catenin, nuclear. It was double reported by 2 consultant pediatric pathologists, and we requested CTNNB1 molecular investigation for confirmation or exclusion of desmoid fibromatosis. It was listed within the oncology meeting with a plan. The plan was to await final histology and obtain opinion by plastic team for surgical management. And the final histology obviously include as well the end or the conclusion of the molecular investigation. So there were issues with surgery because the second surgical specimen we received on the patient before the completion of the molecular investigation. So we supposed to wait, and the surgical specimen was received before the conclusion. The original pathologist was informed from the molecular investigation that was failed, and it was going to be repeated, and it was repeated in this new tissue. What happened with pathology? We received the sample, and it included an extensor tendon biopsy, and it was reported by a different consultant pathologist that was not involved with the original diagnostics. But when we received the referral paperwork, it was stated as known desmoid fibromatosis, desmoid tumor. Remember that we say we were awaiting clinical molecular analysis. The lesion appeared very similar to the original histology, was incompletely excised, and however, again, no inclusions were seen on the trichome stain. We repeated the molecular investigation, and the CTNNB1 mutation was not found. So it was not a desmoid fibromatosis. What happened in oncology? The patient was not listed for discussion at the oncology MDT meeting and did not receive the oncology follow-up or input. And the oncology team were unaware of the second surgery. So you can see that the 3 aspects, 3 corners of things go wrong. So the patient, the lesion recurred 8 months later. There was an MDT discussion that included amputation, discussion with about an amputation, and the specialist opinion was sought. However, the histology was reviewed, and the trichromic was repeated, and inclusions were identified. So it was an inclusion body fibromatosis, and this required conservative management. Thankfully, the patient has not gone for the amputation, but however, we reported this as a DATIX, and it was a proper investigation by the trust. So this is the original trichrome stain, and this is the characteristic nuclear inclusions that are visible with the trichrome stain. So what went wrong? In the trichrome stain, the stain was undertaken by an inexperienced member of the staff, and it followed the SOP and the manufacturer protocol, but the SOP had not been updated, but the senior BMS saying that a different time for that stain was needed. And it's important because it should be checked after 3 to 5 minutes, and the stain was left for 15 minutes. So the 15 minutes extra time made the stain negative. So that's why the red inclusions would not be identified. However, the stain was still quality checked by a more experienced member of staff. And the primary purpose of the stain is for elastic tissue, it's not for inclusions. So also we had failed based on a wrong control tissue. So the MDT instructions at the oncology meeting, the suspected diagnosis of desmoid was awaiting molecular confirmation, but the second surgery took place before the results were available. Had we received a negative or failed result, this would have led to MDT discussion with the options to repeat the investigation, repeat the special stain, ask for a second opinion. The surgeon who undertook the procedure was not in attendance to the oncology MDT, and I was actually a locum surgeon. And the second surgeon was in attendance and communicated that surgery was to go ahead without the final genetic test results. So you can see errors in communications. So the learning point, standard operating procedure to be updated with short differentiation time for this specific lesion. New control tissue use, a reference case for use of stain when investigating specifically for inclusion body fibromatosis. Surgeon undertaking the operation should attend the oncology MDT. Don't leave it to another consultant. And we need to review the pathway of children with soft tissue lumps. Despite errors, there was evidence of good practice and multiple systems in place to protect against error and act and safety net. There was double reporting by consultant pathologists, quality check procedure in the laboratory, use of ancillary investigation for confirmation of the diagnosis, prompt discussion at MDT with quick referral to plastic team, and clear MDT documentation with plan from initial discussion. Really, medical errors can be attributed to a single action, typically a combination of multiple errors, which can occur even when defense mechanisms are in place. Thank you. That is my case.
Thank you, Marta. Really good example of the Swiss cheese model. So moving on to our next case study, I'll pass you on to Bernie.
Hi, everyone. And now for something completely different. I'm going to talk about an area of biochemistry that fills me with dread usually, and that is the topic of metabolic disorders or inborn errors of metabolism. When we think about different pathways that exist across all of our different types of cells and organs, there's a whole host of places in these metabolic pathways where things can go wrong, and it's very, very complex, and you're on a bit of a treasure hunt to try and find out where the defect is and then what the consequences are. This is a sort of simplified set of pathways that many of you will be familiar with, certainly from undergraduate teaching and so on. And these are the pathways that manage the metabolism of complex carbohydrates, proteins, and lipids. And what tends to happen is that we can develop a block somewhere along these pathways. And when that block develops, what you see is the accumulation of products before the block and a deficiency of products after the block. And it's this combination that causes the presentation of the various clinical ways in which patients can present. Another thing that fills me with dread is being faced with a sick baby. And that's the same whether it's your children or your grandkids, but also within your job within hospitals. And you know, I rarely get a phone call. It's usually in the middle of the night, and it's about a particularly sick baby in the neonatal unit. And the typical presentation is you know, the history of a baby a few days old, not feeding, crying all the time, maybe seizures, vomiting, and sometimes fever. And when you speak to the neonatologists and even the emergency department, because these babies and children can present at any time, they're really looking at 5 big areas: infection, cardiac, injury, surgical, and metabolic. The clues that could be metabolic are things like hypoglycemia, reduced GCS, and vomiting, and some other features that are listed on the slide. And you really have to have an index of suspicion that allows you to then think, well, what tests should I do next? And this is where you have to get it right, because if you fail to carry out the correct basic tests, then you can miss something and you could cause huge delay in the diagnosis and, more importantly, the treatment. And in these situations, you know, hours really matter. The kind of testing that we would do along with basic biochemistry of things like ammonia, vitally important, arterial blood gases, looking at pH, lactate, and calculating the anion gap, and also blood glucose. We can also take off a sample for urine at any time, and these can be measured for organic and amino acids. Amino acids can be measured in the blood as well. The latter tests, however, these organic and amino acids can take many, many days to come back, but it's worth getting that sample off early. The treatment options for these babies is vitally important, because you would instigate treatment before you've really diagnosed. And one of the most important things to do is to stop the feeds. Stopping the feeds are important because the baby's feeds are essentially driving all of these pathways, and feeds generally contain carbohydrate, protein, and lipids. So it's important that you stop those pathways as much as you can, because that could be generating the metabolic consequences. Usually you can start intravenous dextrose so that you're not introducing catabolism by not giving them any nutrition at all, and that intravenous dextrose provides some calories. General rehydration is important, and you might want to think, depending on how high the ammonia is, to instigate early ammonia scavenger type drugs. And of course, most importantly, seek advice. Even in a large tertiary hospital like my own in Aberdeen, we have a system in Scotland whereby there is a metabolic physician on call, and that metabolic physician is usually either in Edinburgh or Glasgow. They are very few and far between, and you would involve them very early, because what's usually needed in our situation is that the very sick babies need transferred to either Glasgow or Edinburgh in order for treatment to begin in those centres, treatments that are only available in those centres, such as neonatal dialysis. I was phoned one night, again, usually at 10 p.m, with the story of a 3-day-old male baby with a history of poor feeding, seizures, and the usual tests were carried out in these situations, and the standout result was an extremely high ammonia result of 2,910. Ammonia is usually well below 100 even in neonates, and the arterial blood gases revealed that this baby was overventilating, was hyperventilating with a respiratory alkalosis. This is usually the situation when you've got such a high ammonia, because ammonia stimulates the respiratory center. But if that's left too long, eventually depression of the respiratory center occurs, and an acidosis and death would follow quite quickly afterwards. Ammonias of this high are usually defined as being almost certainly due to a urea cycle defect until proven otherwise. So treatment of this particular baby, again, as I mentioned before, stopping the feeds, especially the protein in this case, because it's a protein metabolism that's feeding this cycle, and introduction of intravenous dextrose, rehydration, and the neonatal unit would also consider using ammonia scavenger type drugs. We sought advice from the metabolic physician unit in Edinburgh, and quite quickly they realised this was a serious case, and we then were able to organise transfer to Edinburgh, which is usually by helicopter, the quickest way to get them there. Urea cycle defects can occur anywhere in this pathway. In this particular baby, however, what we found eventually when the full testing panel came through was that the citrulline was extremely high, and in combination with a very low arginine suggested that the block was in the arginosuccinate synthetase enzyme, this one here, and that's a typical case of citrullinemia. Ornithine was also significantly reduced. So it's really cutting off this part of the pathway. But the bit before the block, you're getting accumulation of all the products, including ammonia up here. Thank you very much.
Thank you, Bernie. Thank you also for that infographic, that five things to look out for in children is something I'll definitely take away from this. Moving on to our next case study, pass you on to Noha.
Thank you everyone for joining today. So I do microbiology and virology, and this interesting case, I thought it fits well with the theme of the day, patient safety in neonates and infants. So this is an interesting virology case, interesting for many aspects. So I'll go through it starting with the mother, who's a pregnant female. I'll call her LS, 31 years old. She had a complicated history. She comes from European background. She's not local. The most striking thing in her history was this obstetrics para 0+10, which in obstetrics terms mean that she was pregnant 10 times and she didn't deliver any baby. So basically she had 9 abortions, and this is her 10th pregnancy. And you can stop and reflect on this and imagine how extremely precious this baby is, and what's the emotional situation of this woman. So when seen by the obstetrician, has been deemed as extremely high risk pregnancy. Actually, the last abortion was maybe a couple of months before she conceived in this baby. So obstetricians at 32 plus 3 weeks gestation seen her pregnancy complicated by elevated bile acids, and the growth was tailing off. The baby was on the 5th centile despite being active, and the Doppler is normal. So a decision was taken to deliver the baby by cesarean section when they reached 34 weeks of gestation. The baby was born prematurely at 34 plus 2 weeks, small for gestational age, with intrauterine growth retardation. Lots of samples sent to the lab. And this is samples sent on day 3 of age, and it's important to identify this day 3. I'll come to it later. Blood cultures were sent in microbiology, negative. Bloods, normal hemoglobin. Blood film show appearance, right, red blood cells, normal appearance, normal for premature neonate. Platelets were low, thrombocytopenia, white blood cells were low, and there was conjugated hyperbilirubinemia. Next are the samples that came to the virology lab, which is the most important one here. So we've received the urine sample and a blood sample tested for cytomegalovirus, which I refer to as CMV, tested in the urine by PCR, which is a qualitative test, detected or undetected. So we detected CMV in the urine, and a quantitative test for CMV in the blood detected a high viral load with a log of 5.1 of CMV in the blood. So given the background history of the mother and the situation we're in, this is a very striking result to have in the lab, and you need to stop and reflect and make a plan on what you think is, how do we evaluate the situation and what's the next steps. Before I go on what we did with this patient, I'll outline quickly what is CMV infection and congenital CMV. So cytomegalovirus is a herpes virus. It's one of those large DNA viruses enveloped, and it gives you this ugly owl-eye appearance in the tissues inclusions. Most people, 50% of the population will get infection with CMV at one point of their life. In a fit and healthy person, there's no or few symptoms, doesn't require treatment. Most people will recover without treatment or without realizing that they got a CMV infection. It gets transmitted from one person through another through infected secretion, be it the urine, saliva, blood, could be in blood transfusion as well, breast milks. Congenital CMV happens when the mother gets infection during pregnancy, and the CMV crosses the placenta to infect the fetus. The highest risk, of course, if this infection happened in the first or second trimester of the pregnancy. If the woman was immunocompromised as well, that will be a more risk. The congenital CMV is not always problematic. So 10 to 15% have symptoms at birth, and that would be neurological or focal in the spleen, lung, liver, lymph nodes, CNS. 10 to 15% as well will be well at birth, no problem, but they will go on later on to have sequelae, which mainly sensorineural hearing loss, which CMV accounts to 1 in 5 cases of sensorineural hearing loss. It's the most common acquired cause of this thing. Now, this is just roughly what do you expect when a baby has a congenital CMV, and what's the problem that we would be facing? Microcephaly, ventriculomegaly, intracerebral calcification, and that this baby had them. Sensorineural hearing loss, thrombocytopenia. We've seen this in the baby, intrauterine growth retardation in our baby, chorioretinitis, and the range of LFTs as well was here, hepatomegaly, splenomegaly. So it's quite complicated. Gives an ugly picture, microcephaly, petechial rash, blueberry muffin rash that we call it, and jaundice. So that's in order to diagnose. I mean, it's a bit challenging how to get a diagnosis, despite having a CMV in a urine sample. It's still tricky to make the appropriate diagnosis and evaluation. There is no national screening system, and this across most of European countries. There is debates around the clinical and the financial value. So there's nothing there. In order to diagnose infection in the mother, the gold standard is serology, which is the IgG and IgM. IgM is gets raised in acute infection and then drops after the acute phase is out. IgG is positive straight after IgM and remains positive for life. So maternal seroconversion is diagnostic for infection during pregnancy. There is the avidity assay that can be done, which tells you how far back was the infection acquired. Is it less than 4 months ago or more than 4 months ago? For the infant, it's himself or herself, they shed large amounts of the virus in saliva and urine. For that, PCR is a highly sensitive assay to detect the virus in those samples. And if there is a high viral load, we've seen the baby here is 5.2 viral load, which is a log, which is high, correlates with markers of active disease, such as thrombocytopenia, which we had in the baby, and the transaminitis as well. The main challenge in diagnosis of CMV at the perinatal stage is distinguishing between congenital and postnatal infection. And for that, we need to test the baby for PCR within the first 3 weeks of delivery, of their life. If we detect PCR positive CMV samples in the baby during this period, this is indicative of congenital CMV. After that, you cannot tell whether it is acquired or congenital. For treatment, not every baby with CMV gets treatment. Antiviral drugs not recommended if they're mild symptoms, but if they have CNS-related symptoms or hearing loss, will be treated. Should be started ASAP within a month of age and can be followed up to 6 years. Back to our baby here. So that on 3 days, that's very early, we detected the virus in the urine and in the blood with a high viral load. This is clearly a case of congenital CMV. We need to make some more confirmation. And luckily in the virus lab, we store samples. So we store samples 2 years, 3 years, according to the capacity of the lab. In my lab, we store samples for 2 years. So we went back to the mother's, we first asked for a sample we went back to the mother's booking blood. So that when she had in that pregnancy early on, around 20 weeks pregnancy, she was negative to IgG and IgM. So she didn't have any CMV exposure at that point of time. So we asked for a sample from the mother now after delivery, and that's what we found. Her IgG is positive and IgM is negative. So she clearly had a matter of seroconversion during pregnancy. Early in pregnancy, she hadn't had an exposure to CMV, and now she had what indicates a past infection of CMV. So between those 2 time points, she had an infection with CMV. The IgM was negative at that point. That could be either she mounted an IgM response and then disappeared after the acute phase, or it was at this stage too low to be picked up. And it's not possible now to do an avidity assay because the IgM is negative. But now we have this diagnostic maternal seroconversion. Now, following up the baby at 2 weeks time during all this, still detected in the urine. We made of course, a complicated like this requires a multidisciplinary team discussion, which includes the neonatologist, the virologist, and the pediatrics infection team. On a scan, the baby showed intracerebral calcifications, which is in line with the congenital CMV, and small intraventricular hemorrhages. So the diagnosis of symptomatic congenital CMV was made at the 2nd week of life. This is the type of patient that I would go myself into the neonatal unit and try to document everything, all discussions in the patient's notes, so that we're all clear on what we're doing. We agreed that this patient requires treatment, and we gave him he was a baby boy, ganciclovir for IV for 2 weeks, and then switched to oral for another 6 months as a suppressive measure in order to prevent development of long-term sequelae with that. On a 23 days follow-up, still the virus is detected in the urine, and that we expect this is nothing to worry about because he's going to shed the virus in the urine for a long time. The virus log here is dropped, like 2 logs drop, which indicating that the baby is responding to treatment. On a 3 months follow-up, virus log is 3.5, still detected in the blood. No neutropenia. The raised transaminases and the bilirubin levels are going down. Good response to treatment. Ultrasound scan, the internal organs are fine. MRI, there is abnormal neuronal migration compatible with the congenital CMV infection, but we don't know how is this going to affect their development. And the initial hearing was fine, which was very good. There's no abnormalities, and there will be further follow-up. Following up at 5 and 6 months, clinical good condition, growing very well, no concern about hearing and sight, developing, smiling, interacting, and as well, most important, tolerating the medication as well, because that can cause disruption in the treatment plan. There was plans for more audiology, arranging a hearing test and physiotherapy review for motor development. Unfortunately, the patient moved out of the area, and I won't be able to tell you the hopefully good news at the other side, but this is where we are. So my point here is what consideration? It's not a matter of a sample that flags in your lab report. The scientist in the lab will flag that this is a significant result and you authorize it. Oh yes, analytically it's fine, all good. So there's many consideration you need to think about when you're dealing with such a case. So the first subject here is the baby himself, the patient himself. The types of lab samples you've taken from the baby. Is it the urine, the blood, the saliva? The timing of the sample, as I said, is very important that you pick this up in the first 3 weeks of age. Otherwise, you kind of lost it in terms of being able to diagnose a congenital CMV. The PCR and how accurate it is, and when do you do quantitative and when do you do qualitative. The ability to do avidity test if you're able. For the treatment, and you need to do a therapeutic drug monitor levels for the ganciclovir to make sure that the baby is on appropriate dosing, and can be very challenging in order to communicate this to the team and get them to get the right samples and send them away and get the right results at the right time. Establishing the diagnosis, which need to be on an MDT basis between yourself in the lab and between the different clinical teams in order to agree that this is the diagnosis we're all happy with. The decision on whether this is congenital and acquired, whether is this symptomatic or asymptomatic. As well, from that decision, do we want to treat or not, and for how long do we want to follow up, and with what do we follow up, what sort of testing? As you can see the urine is still positive for CMV. Are we worried about this or not? So explaining all these details to the team and understanding how the follow-up can take place and what does it mean is an important thing. The second part that you need to be concerned about is the mother. So we diagnosed an infection of CMV here in relation to the mother. The mother got infected. Is she unwell now? Does she have any infection? Does she need treatment or looking after? So that for her case, or in our sample, we didn't. She was fine, but this is something you need to consider. There is the element of counseling and family planning. Does she need to get more? She wants to get more kids later on. Does this affect the future for her? And that she need to be referred to obstetricians and follow this. There is the social and emotional burden on this family dealing with the kid with this complexity. The other item following from that is the infection prevention control. So you have this baby sitting in the neonatal unit shedding large amount of the virus, the CMV virus, which could be a killing virus for some vulnerable children. So how to implement appropriate infection control measures in the neonatal unit and protect the rest of the patients, and how to protect the healthcare workers themselves to prevent them from transmitting infection from one another, and if any of them was in themselves a pregnant woman or an immunocompromised vulnerable personnel. So you follow standard infection prevention control measures and transmission-based precaution, hand hygiene, the waste disposal of the clinical waste, how do you dispose of it? Cleaning, disinfection, multiple use equipment, education training of staff, and prevent any pregnant healthcare worker from caring with this baby. The last bit is the public health, the risk to the public health. So is there any risk to the wider community once this baby goes out in the community? Yes, there is. So the baby will be persistently secreting high level of the virus concentrated in the urine and saliva for some time. So if any pregnant woman looking after this baby, she needs to be careful. Or if the baby is in contact with any women in childbearing age, so a mother in this stage will take the baby to the vaccination, to the GP, and in places where there be other children and other pregnant women. The mainstay of intervention remains education of the pregnant women regarding sources of exposure and behavioral interventions to limit their exposure to CMV. And this is my case. Thank you.
Thank you, Noha. That's fantastic. A good outcome on that case. So we will come on to the Q&A shortly, but just before we do, we had some time set aside for some general discussion and lessons learned from these case studies relating to patient safety. And I had a couple of things, as you've presented, that I've taken out as sort of themes relating cross-cutting across these. I'm very interested in our three presenters in terms of what their take is. So the first was, you can see there's an issue around sort of communication between clinicians, MDTs, and pathology departments, and particularly in the context of, see there's a national drive to try and rationalise and streamline MDTs, particularly for patients who are eligible for standard of care treatment. How do we balance streamlining those MDTs for efficiency, whilst at the same time trying to ensure that we've got appropriate communications between pathology departments and other clinicians in an MDT to ensure that patients are kept safe, and for those who are more complex, that you have a sort of joint decision-making process that's appropriate. I think it's very complicated. I think it's a very difficult thing to fix, but very interested to hear opinions from the floor.
If I can go first, because our case was clearly a lot of issues of miscommunication. In the lab, the person who was doing the stain didn't know of the trick of making a shorter stain timing because the senior wasn't, and all of that needs to be, obviously the SOP are important, and that we need to follow guidelines. If we don't follow the guidelines, the recommendation, the SOP, etc., but at the same time going to MDTs, especially when we have a very reduced workforce in all specialties, and we have a lot of use of locums that come and cover these sessions and then go, and there is no communication with it. I think that is important, and it becomes very key. The administrator of the MDT, the administrator of the MDT, who needs to be a person who knows that all steps have been followed for that MDT to reach a decision. And I think that in the future, operational systems using AI will be very helpful. And that needs to be embedded in the history of the patient, in the clinical record.
Thank you, Marta. That's very interesting, particularly use of AI. Bernie?
Yeah, communication is key, and my case illustrated, a presentation that could not take hours even or days to work out what was going on and suggest management or diagnoses. It was about being able to act there and then, and make sure the right tests are done at the right time in order to try and establish whether that sick baby was very, very ill or not. And so it's important that we have that battery of tests available 24/7, ready to go. And once that very high ammonia is detected, that immediately should trigger action to involve metabolic physicians in order to try and establish how we can manage that baby, both in the short term before transfer, but also once to get to the transfer specialist unit. It's all about trying to reduce that ammonia, because that baby will die because the ammonia is high. What the inborn error is less important at this stage. We establish that much later on, and there are obviously then treatment options. In this case, urea cycle defects you can manage, into adult life with low protein diets and supplements with some of the amino acids that are maybe deficient. And so it's about establishing how sick is the baby, and remember, most sick babies don't have inborn errors. Inborn errors are rare, but once you get those key, triggers, those key signals of high ammonias, and maybe even low glucoses for other things, you can then establish a pathway. So it's about making sure the neonatologists are up to speed with their guidelines, that the laboratories are equipped to deliver those initial tests 24/7, and you have those links then with the specialty units for managing those very sick babies once they're identified. Thank you.
On that note, Bernie, I mean, I'm not, it's been a long time since I requested a biochemical test. For that ammonia test, the requesting of it, how much input is needed from the pathologist to help the clinician choose the right test at the right time? And this isn't just for biochemistry, I mean, this applies to all pathology disciplines, but how much input was there in that example?
No, I mean, that would all happen, or it should happen automatically. The neonatologist, when faced with a very sick neonate, will generally, do many of these tests: arterial blood gases, ammonia, glucose. That's the standard panel that you would do at least once in order to establish if there was a serious issue, and then take it from there.
Thank you. So I'm just open for now if you had anything else to add on MDTs and communication.
I think it's very important, if you don't, from maybe from the infection side, from my angle, is to establish a sort of a regular MDT in relation to pediatrics, which is something that we've established here on the background of a consultant of pediatrics infection who was interested. How they persevered when they came to my hospital, how they persevered. And at some point there was like no one is attending except of one or two attending those MDT, but by pushing it on and showing the value for the patient or for the education as well for the staff on those ones, it became a very big thing, and it's now for many years. So persevering into this is very important. It is in the interest of the patient and in the interest of the better care. The other thing, you can call for an MDT yourself. I mean, in our case here, we call for the MDT, and we call for the right parties to get involved. This is something, if something is needed, multidisciplinary discussions, you have to call for it, and you have to make sure that the right people are in the place, understand the difficulties and people's times and commitments. But when it comes to a significant case like this, most of the people will be willing to come and join into agreeing a time that suits everyone and have their input into it. So it requires a bit of a push and persevering and recognizing the value of this type of discussion for the benefit of the patient care.
Thank you. Then one thing, Marta, in your case study, one thing that really struck a chord with me was about the senior biomedical scientist not having the time to update the SOP. I think that really sort of perhaps is representative of the state of laboratories across the country, where we are, so short-staffed that even though we are aiming to try and integrate quality into our lab processes, typically quality is one of the things that sort of is first to fall by the wayside when backs are against the wall and time and staff are limited. So I just thought it was just an interesting thing to see, that I think it really reflects the state of path labs, at least in the UK at the moment.
Yeah. But I must say that, as you know, this trichromic stain is for fibrous tissue. So the control was correct. It was being approved by UCAS. The SOP was reflecting, the manufacturer was, how a trichromic stain should be done. What happened is that We didn't know, we the consultants, I requested the first, then my colleague requested the second, and then she persevered into what happened. This is Sophie who actually got to the bottom of it, because I had the first half, she had the second half. But what happened is that this particular inclusion is seen with geochromic when it is a short, just 3 to 5 minutes staining rather than 15 minutes, as the protocol says. So the protocol was followed, but it's true that this senior BMS who has not updated, and he was on holiday or away, so he didn't do it. And the person who followed the SOP, it wasn't there. So that's why it's so important to follow the SOPs and the guidelines, and obviously to update QPULs as we have them. But one thing that I was just thinking when Bernie and Noha were considering about the communication, on top of the MDTs, what I found very useful, but I've been working 22 years in this hospital, so I know most people, is just call them. Call the consultant and say, look, I have this impression on this case. What do you think about that? Or sometimes they call me to say, they call me to have a complete a picture of the clinical aspect, and I need to do the clinical pathological correlation. So don't underestimate or desestimate the importance of just calling the consultant who is responsible of the patient and have a discussion that is important to inform your diagnosis decision making process.
Absolutely, I couldn't agree more. So we've got a few things up in the Q&A. I think Bernie and Noha, you've answered a couple of them. So if anyone wants to see the answers to those, just open up the Q&A tab. I think Bernie, there's a comment here about see lots of similarities with inborn errors of immunity. And if the right tests are not requested, then diagnoses get delayed, and for some, it comes too late. So they're saying that clinical teams are encouraged to call their local lab specialist to get advice. I guess that doesn't guarantee that they will do it, but there's only so much you can do, I suppose. There's also, on that point, I've always thought about, is there a role for web-based resources, whether it's at local, regional, or national level, to try and guide clinicians? But again, it's a case of they need to read it before to get any benefit from it. I don't think anyone on the panel has got any experience of using that sort of arrangement to help the clinicians choose the right test at the right time.
Yeah, certainly neonatologists will be well versed with dealing with sick neonates and what tests to do and what to do next. Most of these babies we wouldn't be phoned about necessarily; they will automatically kick in. But every sick neonate with an inborn error doesn't always present typically. And there may still be some confusion or some testing that sends you down, a sort of different road that is not correct. I mean, this is where, given the complexity of inborn errors of metabolism, it's really open for some sort of pathway AI solution in the future, whereby the combination of clinical features and test results as they begin to build can then feed into an AI algorithm that can help the clinician decide what to do next. And I'm quite sure that's the sort of thing that will certainly develop in this sort of area.
So Marta, I think there's a couple of questions, 2 related questions about your case. One was about obviously the clear communication and continuity of care is an issue, and do you think some of that is due to workforce gaps? But also related to that, they're asking about how much of an impact does locum staff have on these sorts of procedures, mistakes and errors?
I think they are both connected, because when we have locums that I respect them and I value very much because we need them, you have somebody who comes to do a particular task, like is take the theater list today. And then they don't go to MDTs because they are just there for the day or for a few days. And the same happened with the staff that we have in the lab, that we have locums, but they don't know the SOPs because they are proper to us, and they are not embedded. So obviously this is related to the workforce gaps that somebody was asking, like Charu Chopra. Yes, this is related with the workforce lab, because if we have a fully staffed laboratories, then we would not need the locums, or the locums would choose to work, more comfortably in a permanent position. But is also that we cannot, it's also the experience. And then we have a lot of, I go to a case that I am dealing at the moment. You may know the Kennedy protocol. The Kennedy protocol that follow how it guides how we investigate the postmortems. So it happened, and it's been a few errors that I realized that new teams come and they are not trained. So they don't follow the protocol because they have not received the appropriate training. So I think that is extremely important that each organization, laboratory, etc., has a mandatory training, that there is an ongoing training constantly. So people that comes is trained, people, and then there is an update, and those that already know can be updated. So I think it's workforce, training, procedures, and obviously all the pressures that we are going on, is really how can I say, it's quite dangerous, that situations, because as a pathologist, I do see many things that have gone wrong because of missing opportunities. And I think this is, we need to be very careful. That's why I was saying about the AI. AI is not ready to make diagnosis for us, is to replace us, but possibly AI is good to an operation procedure and see if something is missing in all these circle that we need to, and pathways.
So one more question in the Q&A section. I think it's directed to you, Bernie. I don't know if you're able to see it. So it was about
Rebecca said, yeah, I mean, she's suggesting that, in the future or even now, we can benefit from more rapid testing, to get more definitive diagnoses earlier. But obviously that takes time, it takes money, it takes expertise, which generally isn't available at 10 o'clock at night. But technology is improving all the time, But would it help the sick baby in my case? Possibly not, because that baby is not going to die from the impact of that inborn error, that urea cycle defect per se. It's dying from a high ammonia, and we can manage that without knowing where the actual defect is. So it's just I would highlight again that, we absolutely need to get the basics right. We have to get the basic testing and the basic treatments right. Stop those metabolic pathways as much as possible until we figure out what is causing it. But yeah, I mean, it's all about specialist testing, really, and my lab in Aberdeen has numerous tandem mass specs and various other things, but we will still send away those specific tests away, to other labs, more specialist, to define what the actual defects are. So it's about affordability, really, more than anything else. I would think technology is advancing all the time, but the NHS in particular can't always afford it, and they certainly can't afford it everywhere. So we have to make that pragmatic decision.
Good point, Bernie. Apologies. No, I didn't. I missed your raised hand.
No, it's fine.
Okay.
I just wanted to comment on what was said in general, and our roles and locums and following SOPs. Some of the complicated cases, we need to be aware of that. Some of the complicated cases come as a dilemma for everyone, not just us in the lab. So I'm facing this result. What the people in the clinicians in the ward looking after the patient, they'll be far more confused than ourselves as well. So we need to be mindful that in some situation it is already difficult, and we need to take the extra mile, and we need to do additional effort, and we need to be kind and patient in our communication, and expect that the message might not fall through, and not demand like, you need to tell me this, they don't know. Simply, that's why this is all this communication is needed, and it will require a bit of more effort to make sure everything is tight, maybe from the lab side as well. Go to the lab and make sure the staff know and understand what they're doing, for just not to miss out a wrong step in the SOP. And the same on my side, if the wrong timing of drug monitoring came, shall we do it or not do it, or ask for another sample, the wrong tubes, we don't need wait and just report it and leave it, because this is a critical case we just communicated. Similarly, many other things, you need to chase the staff in the ward to make sure they understand what they say in a shift and a night shift, that they're not sure has it been communicated. So it requires an effort from different parties when it comes to a complex case. Expect that people would not know what they're doing, but if you communicate things well, you're likely to get the desirable outcome from your intervention and your management. Thank you.
Thank you. So I'm just mindful of time. I think we've got time possibly for one, maybe two more questions in the Q&A. There's a comment here about communication being central to best management, and errors that have arisen as seen in the cases we've discussed. If there is an issue and with staffing and reliance on locums as a problem, is it not better to say as a service that you can't support the MDT, and therefore the MDT would then be aware that they need to be more attentive to results? In my view, I would cautiously agree with that, having seen that implemented in my own trust, but would open that to our panelists.
I don't agree with that, because I do a lot of GI in a pediatric, and a few times I have caught that there is misinterpretation of the report. Even saying that when it is. So really, I think it's important to discuss cases and MDT. This should be part of our job plan, and we need more staff. It's not just dropping the quality. If you drop MDTs, you drop the quality, because there will be a lot of missed opportunities for misunderstanding. And that's why it's important to have this, communication in which we discuss a patient from both sides, and we work at the interface of both specialties. So I disagree with dropping the MDTs.
Yeah, I think just adding to that, as we see an increasing, imbalance between the workforce and the workload that we're presented with, and that's not going to get any easier, certainly not in histopath, then we have to ensure that we try and preserve, patient safety as much as possible so that those errors are minimized. But it is difficult when we've got locums who are here today, gone tomorrow, and also, we're sending increasing numbers of our samples or specimens out to backlog type services, which again have variable input to MDTs, and so it's important that we ensure that there are pathways within each of our organisations to adjust and account for that, because at the end of the day, if there's an error made, the finger will be pointed at the department, not at the locum or the backlog service, because they've fulfilled their contract.
No, did you have one? Did you want to make one last?
Yeah, no, I mean, I agree with what said as well, and I agree with Marta. I mean, our primary objective of our role as medics is to provide clinical service, and we have to make a place for that. If we're not able to support a formal MDT, we should be able to make time to communicate properly what we want to communicate and listen to the clinicians around the case. So it is a priority, and we need to make a place for it.
Thank you. Sorry.
Sorry, I just wanted to say to John Murphy, who is the last question, that this is running the staffing first, and then MDT will be provided effectively. Of course, we need the staff, and this is what we are saying. The workforce needs to be make stronger so we can maintain MDT's good quality patient safety.
So on there's one question which we won't get around to answering, but if that individual, I don't know who it is, wants to drop me an email about training locums, I'd be more than happy to give you my opinion based on experience in Cambridge. So that's really all we have time for today. Thank you again to our speakers for all of those three very intriguing case studies. Thank you to you, the audience, for being part of this very important discussion. I hope today's session has left you feeling sort of inspired, informed, empowered to champion patient safety in your own practice and perhaps change your practice slightly on a day-to-day basis. The recording will be made available on the RCPath website. So if you or any of your colleagues aren't able to see all of this, you can watch it at your own leisure. The guidelines team will be sending around a short feedback survey. We'd very much appreciate and love to hear what you thought of today's webinar. And again, tell us how you're making World Patient Safety Day on X, formerly known as Twitter. Again, hashtags are World Patient Safety Day and RCPath Patient Safety Day, and tag us at RCPath. Thank you again. Goodbye and have a great day.
Bye.
Bye.